Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
Today's podcast episode is with Dr. Costa Sousou, who is a OBGYN doctor and has been since 1994, so has been practicing for over 29 years. Thank you so much for being on here with us.
Thank you.
Yes, we appreciate having you, your area of expertise. And you also right now, if you can explain what you're doing and also with your podcast as well.
I have been in practice for 29 years, and I stopped fully practicing in 2022 and have been doing locum work, which is essentially where I go ahead and provide assistance to other places in the country. So I can do a weekend here or a full week there in covering OB and GYN. At the same time, over the last few months, I put together my own podcast. It's called A Guide to Better Women's Health, where each episode comprises of either an OB or GYN related issue. I think the feeling is that there are a lot of women out there who are either not seeking medical care or OBGYN care for that matter, and who need to at least be able to hear some information about it. My first episode was, for example, on cervical cancer screening, which, you do know that a lot of people probably are not aware that you can get, cervical cancer from the human papillomavirus, which is an STD or sexually transmitted infection, but it's not something you can visualize or feel. So a pap smear done on a routine basis is important. Also talked about the human papillomavirus vaccine, which is out there. It's Gardasil. It's given as 3 injections, and it helps decrease the risk of cervical cancer. And most recently, I've been doing some OB-related issues such as pre-gestational diabetes, gestational diabetes, I should say. And this most recent episode was, in fact, on stillbirths, where I talked about the incidence, the risks, the possible causes, which we never know exactly 100% each loss's cause is, and of course strategies in hopes of preventing any future losses. Absolutely. So that's where I am at this point. Yeah.
Oh, that's great. Thank you so much for sharing that, Costa. And,
You're welcome.
I think it is so important. I think, as mothers, we, put our other family members first, and us doing preventative care or going for our routine checkups always isn't in the forefront of our mind when we have so many other balls that we're holding up in the air. Yes. Having that as a resource is great, just, for us to be educated and to be able to take care of ourselves, right? Navigate for ourselves, which is what we're all about too. So that's wonderful. I think I would love for us to discuss, pregnancy loss, miscarriage, stillbirth, those kind of things, because, we have survivors that are on here listening who are dealing with this, and living with this kind of loss. And I think also, too, something that is extremely as important is how do you pick your OBGYN? How do you have that relationship, especially when we are going through these kind of traumatic losses? And then if we decide to get pregnant afterwards or have that trust built up again with our OBGYNs, and it's not anything they did, but it was just from the trauma of the whole experience of baby loss. So, I would love to know, how do you choose an OBGYN and those kind of things from your perspective?
Well, I'm going to say, first of all, that would be a hard question to answer because, but at the same time, I should say that obviously an OBGYN that you pick should be board certified. Right. That means that they've gotten a certification. They're a fellow of the American College of Obstetrics and Gynecology, which is, where the certification comes from. At the same time, it's also important to pick an OBGYN that's associated with a larger facility. Back east when I used to practice in New Jersey, we used to have a private practice and we had privileges at a hospital where we delivered our babies or did our surgeries. Most recently, before I stopped doing it in 2022, I was working at Mayo Clinic Health System as an employed physician, and Mayo Clinic Health System delivered babies at that time from 23 weeks on. And so we've had our fair share of high risk pregnancies and are associated at that time, or still am, of course, but I'm not there anymore, but are still associated with the Mayo Clinic in Rochester, which is a world famous hospital. So I was privileged to be able to contact any maternal fetal medicine in the event I had some questions too, because we don't always have all the answers. But I think an OBGYN needs to be a good listener. He or she, I shouldn't say just he, sorry. He or she needs to be a good listener and should also take into consideration the full perspective of the patient. It's always best, heaven forbid a person has a loss, it is always best before they attempt to try again to go through what we call a preconceptual counseling. This is where you go through the process of, going over all your medical issues, all your any social issues, whether you smoke or you do vape or, marijuana, alcohol, etc., and any family history. Because, for example, if you have a family history of what we call antiphospholipid syndrome, which is a genetically acquired disease whereby you increase the risk of clotting of blood, and that can be inherited. And so that you may have to be on, let's say, a blood thinner, like Lovenox, for example, during a subsequent pregnancy. And you may not have known that. So by having all that information ahead of time before you attempt to get pregnant. But like I said before, choosing an OBGYN is not an easy choice. But if it is somebody that you can stick with, it should be somebody that is a good listener, that is willing to work as a team with the patient in order to help them through the whole 9 months of pregnancy.
Right. And I think that's wonderful. And I'm glad that you brought
Yeah.
up all of that. And the hospital
Yeah.
system is so important. We've talked about this before, choosing a hospital system that has a lot of capabilities. And we never saw it, with our daughter that we lost and things like that. When we were looking at the hospital, we didn't think about a 3-level NICU versus a 4-level NICU. We
Yep.
didn't look at, those kind of things. And also the hospital rankings, and why they're in place for a reason. And Mayo Clinic being one of the top rated hospitals for a reason because of their capabilities and their surgeries and outcomes and all of that. It is just so important. And I love that you brought that up. And the listening piece too, because I feel like sometimes, and not speaking for all survivors, but, something that we discuss in support group is sometimes our feelings or concerns are brushed under the rug by our provider because, we are hormonal during pregnancy. We worry, of course, because
Yes.
pregnancies and the birth process never go as planned as we hope. And but then when that happens, and then something horrific happens like a loss, it's just so hard for us because it's like we knew something was wrong, So I love that you said about, them being a good listener and being in tune with you and your history and just knowing you as a person. So that's
Thank you.
wonderful. Yeah. After us survivors go through a loss, what do you think survivors can do with their OBGYN? Like you said, you can sit down, go through a pre-screening process and all of that, but is there anything else that they can do for the pregnancy after?
Well, I think just being in tune with the pregnancy itself. Obviously, you have to come to the realization of what resulted or what caused the previous loss. So, for example, if the previous loss was due to a disease that was uncontrolled, like diabetes or high blood preeclampsia, for example, which is severe high blood pressure in pregnancy, those are things that when you sit down with your OBGYN, then they can help screen for those diseases and can address them and can manage them early on. And also, we as OBGYNs have come to the realization that when somebody has had a loss, and when I say a loss, a stillbirth or a miscarriage, we kind of differentiate those a little bit because if you don't mind, I just want to point those out.
Yeah, absolutely.
Um,
Please do.
a miscarriage would be something up to, let's say, 12 weeks, where 50% of the time it's a genetically related issue. Whereas a stillborn could be related to other things, like I said, diabetes, high blood pressure, early, for example, premature rupture membranes, for example, if they broke their water, could also result in a delivery early on, which, of course, if it's very early, it might not survive, such as unfortunately what happened in your situation. At the same time, you want to be able to coordinate with them during the future pregnancies. A Any special testings that will help them identify if this is going to happen again, and then B, usually we do early ultrasound to verify the due date, because obviously, if somebody's had, let's say, a stillborn later on in the pregnancy, you want to make sure that you have an exact timing of their due date. And sometimes we end up delivering them, let's say, a week before, so that it helps ease their mind, because there's no sense in waiting until their due date, especially when the potential risk is there. You also want to talk to them about doing growth ultrasounds, because a growth ultrasound will identify what we call intrauterine growth restriction. And intrauterine growth restriction is important because it might mean that the placenta is not functioning very well. And that might be related, like I said, to certain diseases such as high blood pressure, diabetes, and so forth. And then also, oftentimes, although it's not necessarily going to prevent, unfortunately, a fetal loss, but doing antenatal testing. Antenatal testing is where we do the non-stress test, where we put them on the monitor, and for about 20 minutes we get what we call a reactive tracing, which is, you get the 15 beats per minute for about 15 seconds, and you get two of those within a 20-minute period, and that is a very reassuring tracing. And you also do a biophysical profile, which is where you look at the fluid, the movement, the tone, the breathing, and so forth. And then, of course, you give those 2 points each, and then the 2 points given for the non-stress test will equal 10. So it'll be a 10 out of 10 biophysical. But can that definitely prevent a future fetal loss? It's hard to say, especially if the fetal loss was not known, the cause of that previous loss was not known. But it does help put some assurances on the mom. It eases her mind. Good fetal kick counts is really important. We still stress that. There are different ways to count your baby's movements. I think the one that I go with, and I think it's a very popular one, is laying on your left side for about 2 hours and picking up those 10 kicks. And if you get them within the first 10 minutes, you don't have to stay there for the 2 hours. But oftentimes as the pregnancy progresses, that, of course, time is utilized because it's not going to move 10 times in 10 minutes when you're like 36 weeks pregnant, as opposed to when you're, let's say, 28 weeks pregnant and so forth. But like I said, the most important thing is the testings and the ultrasounds to assure growth, and oftentimes the antenatal testing to at least give mom peace of mind. And then, of course, 39 weeks nowadays, with some studies have shown that you can even induce them at 39 weeks, you'll have still a good outcome. It would be a good idea to consider induction of labor or C-section, depending on which way they delivered before, or which way they want to be delivered, at 39 weeks, because you don't want to pursue the pregnancy beyond their due date, because, as you know, if it goes quite a bit beyond the due date, there are higher risks of stillborn at that point.
Absolutely. And I appreciate you saying that so much, Costa. And, what you kind of said too before, and, just diving into this a little bit more, the causes and preventatives with stillbirth. Can you get into that just a little bit for our listeners?
Sure. Sure. Well, the causes. I mean, there are multiple potential causes. Like I said, one I would look at is uncontrolled diabetes. Okay, because uncontrolled diabetes, if your sugar level is so high, there are all different potential risks for that. If your sugar is very very high, early on in a pregnancy, you can have some congenital deformities of the baby. If your sugar is very high throughout the pregnancy, you can risk a baby that might be too big or might be too small, but also, more importantly, you can risk the potential for a stillborn. Similarly, if you have high blood pressure in pregnancy and your blood pressure is out of control, you're not on medication, whatever, that could also potentially lead to placental damage, which could lead to a stillborn. Infections are hard to predict because it doesn't mean just because you had an infection in the first pregnancy where you had the loss that you're going to have a similar infection in the subsequent pregnancy. But sometimes that can be the source or the cause of a loss. Trauma, of course, can be obviously a source of loss, which doesn't hopefully repeat itself. Twins. Okay, you can have twins which are identical twins because when you have identical twins, they share the same placenta, and so we wonder whether or not, or not wonder, but we talk about whether or not one twin is taken away from the other twins. That's called twin to twin transfusion syndrome. One twin is very small and the other twin is very big. Neither twin is going to do well, but the twin that is very small potentially will have a loss. And then, of course, like I said before, the antiphospholipid syndrome, which is where you are referring to a disease where there's an increased risk of developing blood clots, and you need to be on a blood thinner. And just as important, we're talking about, for example, genetic issues. There are extra chromosomes. Chromosome 21, if there's an extra one, that's called Down syndrome. But there are other diseases that do not survive, such as chromosome 18, chromosome 15, 13. Even though they may survive most of the pregnancy, they will potentially result in a stillborn. And if you don't get those tested for early on, you may not know. And nowadays, you don't have to have an amniocentesis to do those tests. You can do a cell-free DNA testing, which is easy to do. We do it after 10 weeks. It's called Maternity 21. And it's relatively safe. It's safe. Of course it's safe. It's a blood test. But what it's testing for is the fetal cells in the mom's bloodstream. And it's relatively effective, is what I meant to say, as far as identifying. Because if it does state that, hey, baby has an extra chromosome number, whatever, then American College of OBGYN does state, please confirm that with an amnio, because you don't want to say to the patient, okay, you have a very lethal potential risk of a very lethal pregnancy, and you probably should consider whatever the case may be. Some people will talk to them, of course, about unfortunately termination because the baby's not going to survive either way. But you should still get an amniocentesis to confirm that. But that said, those are not as common, but yet those should still be tested for. And that's why all that can still be done through your OBGYN with the help of a maternal fetal medicine physician in the event that needs to be done. And the fetal medicine or maternal fetal medicine physician can also do what is known as a level 2 ultrasound, because a level 2 ultrasound is going to look at those intricate parts of the baby that you don't necessarily see with just a routine OB ultrasound. And then if there is any diabetes, you also do what they call a fetal echocardiogram, which is to look at the baby's heart, because there are potential risks to the baby's heart when the diabetic a person with diabetes, let's say, is not well controlled. So those are things that potentially are the sources of a fetal loss. But as I said before in the beginning, there are fetal losses which we never know. For example, people think a true knot in the cord is a source of a loss. I've seen several true knots in the cord, and the baby comes out crying. There's no issues. It doesn't mean that the cord is so tight that it cuts off the blood supply. Potentially, it could. Similarly, if a cord is around the neck, we see that so often. And all that can do is maybe, the monitor may show some what we call decelerations, but it doesn't mean the baby's gone. And so you just don't know. Placenta abruption. If the placenta tears off, placenta abruption can be as a result of uncontrolled high blood pressure, because the placenta potentially could tear off its source, or it's off the uterus, I should say, and that can result in a decreased nutrition for the baby, which eventually causes the baby to demise. And there's one that is rare, of course, less than 1%, and that's called a uterine rupture. If the uterus ruptures, it's as a result of maybe having had a previous uterine surgery, which is usually the most common thing, like a myomectomy, which is to remove fibroids, or a previous cesarean section. But oftentimes, we still recommend somebody who's had a previous cesarean section, if they had it for certain reasons, that they can still potentially consider having what we call a VBAC, or a vaginal birth after a previous cesarean section. But they should know that there is that less than 1% risk of the uterus rupturing, which could ultimately result in fetal demise, or at least fetal damage and so forth.
Absolutely. Well, thank you so much for that, Costa. And, just hearing you speak about all of this, our pregnancy after our loss with Brooke, with our rainbow baby, we got a lot more of ultrasounds done. We had a lot more blood testing that was done. And not that we didn't have a high level of that before, because I was 35 with Brooke. So they treated me like a geriatric pregnancy, advanced maternal age. I can't believe I was called geriatric. But I like the advanced maternal age. Just a little pill, easier pill to swallow. But, also having a previously healthy pregnancy and delivery, it's, they say it's not as common, or that you would have issues with the next one. However, when we did with Brooke, and then the way that they treated us with our rainbow baby, it was amazing to have that level of care, because of having all those different tests and to understand more, so we could advocate for ourselves, right, to educate ourselves. So I love that you say that. Yeah,
absolutely. And by the way, geriatric is not a term we as OBGYNs use. It is a CPT code provided by your government.
Okay. That's good to know. Yeah.
That's unfortunately, we try to put in advanced maternal age, and it doesn't show up on the coding. But when you code her as I don't even know, it's called geriatric, but either way,
I know.
I just want to set the record straight.
I'm glad you said that. Thank you.
And being 35 is actually quite common to be pregnant, because a lot of women, as you know, have their careers ahead of them first, and they want to get that taken care of. There's no reason why they shouldn't. And with all the special testings and all the stuff that's going on these days, it's okay to, wait until you're in your 30s to get pregnant. Sure.
Yeah, absolutely. And thanks for sharing that too.
Yeah.
Yeah. And exactly right. And just having, like I said, getting all those genetic tests, it was interesting, because we got, with our rainbow baby, we had a 400 panel done with just a blood prick. And it was really interesting that it could tell us so much genetically with our rainbow baby to understand. Now, we didn't thankfully have anything that was, anything to be, but we were able to educate ourselves. And that was what was really important, because I didn't want to have any of the unplanning again, or those like abrupt news, if we could prevent it, in any way possible. So, what is the best way for survivors to advocate for themselves with their providers?
I think that good communication is really important. Talking to your provider, your OBGYN, your midwife for that matter, about what had happened, and asking them for some resources that they can, help you with. I would not Google anything first of all,
Right.
but we do provide a lot of resources. We do provide, for example, when I worked at Mayo, they had Mayo related printouts that they can give to patients regarding this, that, or the other thing. So getting those resources, but that first visit, that very first visit to your OBGYN, whether it be the preconceptual counseling before you conceive, or whether it be the first visit to tell them, hey, I'm pregnant and I had a loss and so on and so forth, that first visit should be very extensive. And like you did, or like you said you had, blood tests, ultrasounds, whatever the case may be, to assure that there is a good pregnancy moving forward. Nobody, nobody can guarantee that a pregnancy is going to be 100%. Nobody can. There's nothing, we don't have a crystal ball. All we can do is do the necessary tests that are available to us to help us identify if there is any potential risks to the mom and the baby, and talk to them specifically about those potential risks and ways of hopefully, in certain cases, preventing those risks. But if the loss was not related to anything specifically, if it was just an unknown, let's assume that somebody had a stillborn at 32 weeks. The baby is delivered vaginally. It looks like it's been, unfortunately, died 2 or 3 days. It does not have any abnormal findings on it. An autopsy is done. Placenta is evaluated, of course it is, for infectious processes, for possible clotting, tears, whatever the case may be. Nothing is found. How do you proceed forward with that? Well, it's hard. It is hard because it's also hard for us as physicians, because we have nothing to go by. So we start going over the process. Okay, so let's see. You lost your pregnancy at 32 weeks. We'll do an early ultrasound to verify you're pregnant, verify your due date. Talk about the maternity 21, the blood test to determine if you have a genetic normal baby. Let's run some extra tests. Hey, maybe mom or grandma or somebody might have had this Leiden 5 factor 5 Leiden mutation or antiphospholipid antibody or whatever the case may be. Let's do that and verify whether or not we need to put you on a blood thinner. Because remember, you don't have to be on a baby aspirin unless you meet certain criteria. You don't have to be on a blood thinner unless you meet certain criteria. We don't just throw everything at mom and say, let's see what sticks. We have to know what we're dealing with. And ultimately, if we still don't know, we will do our necessary due diligence. Serial ultrasounds, meaning that you get an ultrasound at 18, 20 weeks for that full anatomy ultrasound, a growth ultrasound at 28 weeks, and maybe even another one at 32 weeks. And as long as the baby's growing, you don't need to keep repeating it. But then doing the biophysical. When do you do the biophysical? Well, a lot of people say do it at 32 weeks. But antenatal testings, usually you want to do it about a week before the previous fetal loss. So, for example, if the mom lost her baby at 32 weeks, the next subsequent baby you should start doing the antenatal testing at 30 weeks. You don't want to wait until 32 weeks because can that prevent future demise? It probably cannot. But if the monitor or the ultrasound reveals something out of the ordinary, the baby's not reactive, or the fluid is low, or the baby's movements are not great, then that means we have to address that. And then oftentimes, was it done once a week, twice a week? That really all depends on the physician. It depends on the center. It depends on if she has any comorbidities or any other diseases going on that would recommend doing that antenatal testing twice a week. And when I say antenatal testing, I mean both the NST, the monitor, as well as the biophysical profile, which is the ultrasound. And like I said, try to get them delivered at 39 weeks. Do not deliver them anytime sooner than 39 weeks unless they have other medical issues that would be required of them to be delivered before. For example, if they have preeclampsia or chronic high blood pressure, then you should deliver them at 37 weeks and so forth. And 37 weeks, of course, as you know, is when the baby is considered term, which usually means that the lungs generally in a good portion of the babies should be mature.
That's good to know.
But that's pretty much it.
Okay, great. Thank you, Costa, for that. And
You're
what?
welcome.
Yeah. So, what is the best advice that you can give someone out there that is feeling like there might be something wrong with their pregnancy, or is one of us survivors, who is pregnant after loss? What can you, leave them with, per se?
Well, I can always say that, at least from my perspective, I always said we're open 24/7. Whether it's me, one of my partners, for sure, but more importantly, you can call labor and delivery and say, hey, I'm not feeling my baby moving for the last hour. They're not going to say, don't worry about it. They're going to say, come on in, we'll take a look. So,
Great.
communication, it's really, really, really important. Being able to be, an advocate for your own baby and for yourself. If you're not feeling right, explain it to somebody. I've had several patients who've come to me and said, I just don't feel right. And they were close to being due. And I don't say poo-poo it. I act on it. I say, hey, come on in. Let's take a look. Let's see what's going on. And we're not doing $1 million workup, absolutely. But we're doing a non-stress test. Hey, your baby looks great on the monitor, but let's do an ultrasound. Let's make sure baby's breathing, moving, tone, etc., etc. And we do that. And let's say we get that 10 out of 10, everything is perfect. And I sit down with her and I say, how do you feel right now? And let's say she says, oh, I feel a lot better now. And I continue that process of talking to her about, let's make sure baby is kicking. Let's do the kick counts. You need to address let's say, for example, if she's not eating right or she's losing weight or whatever, we talk about the diet. We talk about maybe just spending a lot more time concentrating on those movements. We're not making anybody paranoid, but what we're doing is we're advocating for them as well. We want to make sure that moms and babies are well. And like I said, nothing is 100% guaranteed, but at least we can do whatever we can to assure, hopefully, that the outcome of the subsequent pregnancies, and I mean pregnancies, are going to be good and full term.
Yeah. Oh, that's great, Costa. Yeah, and I know that I always felt some sense of relief when I would call into labor and delivery, based on my doctor's advice and say, whenever you have questions or like you said, you're feeling a certain way, to just come in because we want to check it out. We want to see because we never will have 100% answers with what happened. So let's just make sure you're okay. And that would give me a couple days, maybe a week of just peace of mind, even just going in and getting hooked up to some monitors, seeing that, the movement for a couple hours is great in there. Because, we can't always feel everything either. So, so I think, yeah, just having that peace of mind. And yeah, so that's wonderful advice. And like I said, we just appreciate you being here, you explaining, this a little bit more for our survivors out there listening.
Thank you.
Yes, absolutely. So we just appreciate you.
Thank you.
Thank you.
Thank you.
Yes, absolutely. So thank you so much for survivors out there tuning in. Please follow and subscribe to our podcast to help us reach more survivors, because that's how we get this to keep growing. And we are always with you, fertility loss, pregnancy loss, and baby loss survivors. Until next time, thanks so much.